Welcome to Pediatric Case Review. Today's lecture covers Apert Syndrome, a comprehensive clinical overview designed for healthcare professionals. We will explore diagnosis, management, and complications through case-based learning. A newborn presents with an unusual head shape and bilateral fusion of fingers and toes. Parents have no family history of genetic conditions. On examination, the infant has a tall forehead and flat mid-face. What is the most characteristic finding in Apert syndrome? Option A, cloverleaf skull deformity. Option B, craniosynostosis with mid-face hypoplasia. Option C, microcephaly with normal facies. Option D, plagiocephaly with asymmetric features. The correct answer is B, craniosynostosis with mid-face hypoplasia. Apert syndrome features premature fusion of coronal sutures bilaterally, creating a characteristic tall, broad skull. The mid-face underdevelopment gives the typical flat facial profile. This combination distinguishes Apert from other craniosynostosis syndromes. Early recognition is crucial for surgical planning. A 3-month-old infant has confirmed Apert syndrome. The family asks about hand surgery planning. Physical examination of both hands is being performed. What hand finding represents the most severe manifestation in Apert syndrome? Option A, simple syndactyly of digits 2 and 3. Option B, complex syndactyly with bony fusion. Option C, polydactyly without syndactyly. Option D, clinodactyly of 5th digit only. The correct answer is B, complex syndactyly with bony fusion. Apert syndrome causes severe hand malformations involving both soft tissue and skeletal fusion. The syndactyly typically affects digits 2 through 5, creating characteristic patterns. Type 1 shows spade configuration, Type 2 creates mitten appearance, and Type 3 forms rosebud hand. Multiple stage surgeries are required for functional separation. A 6-month-old infant presents with developmental concerns and unusual facial features. The parents noticed widely spaced eyes and prominent appearing eyes since birth. Physical examination is being conducted. Which facial feature is most characteristic of Apert syndrome? Option A, micrognathia and glossoptosis. Option B, hypertelorism and ptosis. Option C, microtia and preauricular tags. Option D, cleft lip and palate. The correct answer is B, hypertelorism and ptosis. The shallow orbits in Apert syndrome cause the eyes to appear prominent and bulging. Wide spacing between the eyes, called hypertelorism, is characteristic. The palpebral fissures often slant downward. These features increase risk for corneal exposure and eye complications, requiring ophthalmology monitoring and potential protective measures. Parents of a newborn with Apert syndrome ask about their child's developmental future and learning potential. They want to understand the range of cognitive outcomes. What is the most accurate statement regarding intellectual development in Apert syndrome? Option A, all children have severe intellectual disability. Option B, intelligence ranges from normal to impaired. Option C, cognitive function is always normal. Option D, IQ directly correlates with hand severity. The correct answer is B, intelligence ranges from normal to impaired. Children with Apert syndrome show a wide cognitive spectrum. While some have normal intelligence, others experience learning difficulties. The average IQ falls around 70 to 80. Early cranial vault surgery to prevent increased pressure may improve developmental outcomes. Each child requires individualized assessment and educational support planning. A newborn with Apert syndrome exhibits noisy breathing during sleep and difficulty with feeding. Parents report the infant breathes through the mouth constantly. Physical examination reveals upper airway obstruction signs. What anatomical factor most contributes to respiratory problems in Apert syndrome? Option A, laryngeal web. Option B, choanal stenosis and mid-face hypoplasia. Option C, tracheomalacia alone. Option D, vocal cord paralysis. The correct answer is B, choanal stenosis and mid-face hypoplasia. The underdeveloped mid-face creates a narrow upper airway with reduced nasal passages. Many infants have choanal stenosis contributing to obstruction. This leads to mouth breathing, sleep disturbance, and feeding difficulties. Sleep studies help assess severity. Treatment may include continuous positive airway pressure or surgical mid-face advancement in severe cases. A 1-year-old child with Apert syndrome presents with speech delay. Parents report the child doesn't respond to soft sounds. Hearing evaluation is being recommended. What type of hearing loss is most common in Apert syndrome? Option A, sensorineural hearing loss. Option B, conductive hearing loss. Option C, mixed hearing loss. Option D, central auditory processing disorder. The correct answer is B, conductive hearing loss. Children with Apert syndrome frequently develop chronic middle ear fluid due to eustachian tube dysfunction. The craniofacial anatomy impairs normal middle ear drainage. This causes conductive hearing loss affecting speech development. Pressure equalization tubes are often necessary. Regular hearing tests and early intervention services optimize language development outcomes. During newborn examination of a suspected Apert syndrome case, you carefully palpate the skull sutures and fontanelles. The head shape appears abnormal. What finding on palpation indicates craniosynostosis? Option A, wide soft fontanelle. Option B, ridged prematurely fused suture. Option C, normal mobile suture line. Option D, delayed fontanelle closure. The correct answer is B, ridged prematurely fused suture. In craniosynostosis, the affected sutures feel hard and raised rather than soft and mobile. The coronal sutures fuse prematurely in Apert syndrome, creating palpable bony ridges. The anterior fontanelle may be small or absent. Clinical examination findings are confirmed with skull imaging studies for surgical planning. You examine a newborn's hands with Apert syndrome. Bilateral complex syndactyly is present. You need to classify the hand malformation type for documentation and surgical planning. What defines type 1 Upton classification in Apert syndrome? Option A, complete bony fusion digits 2 through 5. Option B, syndactyly with separate thumb. Option C, free thumb and fifth finger. Option D, polysyndactyly pattern. The correct answer is C, free thumb and fifth finger, known as spade hand. The Upton classification helps surgical planning. Type 1 has separate thumb and little finger with fusion of middle digits. Type 2 shows simple thumb syndactyly creating mitten appearance. Type 3 involves complex thumb fusion forming rosebud configuration. Classification predicts functional outcomes and determines timing of surgical releases. During complete physical examination of an infant with Apert syndrome, you assess both upper and lower extremities. Bilateral hand syndactyly is documented. Now examining the feet carefully. How do foot abnormalities typically compare to hand involvement in Apert syndrome? Option A, feet always more severely affected. Option B, feet usually less severely affected. Option C, feet never show syndactyly. Option D, equal severity in feet and hands. The correct answer is B, feet usually less severely affected. While syndactyly occurs in feet, it's typically less severe than hands. The great toe commonly shows fusion with second toe. Broad big toes are characteristic features. Foot syndactyly rarely causes significant functional problems. However, complete documentation is important. Surgical release may be considered for severe cases or cosmetic concerns. A 2-year-old child with Apert syndrome presents for routine follow-up. Height and weight measurements are being plotted on growth charts. The child has undergone craniovault surgery. What growth pattern is most expected in children with Apert syndrome? Option A, accelerated linear growth. Option B, normal growth velocity. Option C, short stature common. Option D, tall stature typical. The correct answer is C, short stature is common. Children with Apert syndrome typically have heights below average. Early fusion of growth plates in long bones contributes to reduced final height. Growth hormone therapy is generally not effective. Regular monitoring on growth charts is important. Nutritional optimization supports maximum growth potential within genetic limitations. A 3-year-old child with Apert syndrome presents for evaluation. Parents report delayed tooth emergence and difficulty with oral hygiene. Oral examination is performed. What dental finding is most characteristic in Apert syndrome? Option A, supernumerary teeth. Option B, delayed eruption and crowding. Option C, complete anodontia. Option D, amelogenesis imperfecta. The correct answer is B, delayed eruption and crowding. The underdeveloped maxilla creates insufficient space for normal tooth alignment. Dental eruption is often delayed compared to typical children. Many patients have high arch palate or cleft palate. Early dental evaluation is essential. Orthodontic treatment and potential orthognathic surgery address severe malocclusion and crowding problems. During ophthalmologic examination of a child with Apert syndrome, you document protosis and shallow orbits. Multiple ocular findings are present. What complication requires urgent attention and intervention? Option A, refractive error only. Option B, exposure keratopathy. Option C, strabismus without diplopia. Option D, mild hypertelorism. The correct answer is B, exposure keratopathy. The prominent eyes and shallow orbits prevent complete eyelid closure, especially during sleep. This exposes the cornea to drying, irritation, and potential ulceration. Immediate treatment with artificial tears and lubricating ointments is necessary. Severe cases may require surgical eyelid procedures called tarsorrhaphy. Regular ophthalmology examinations prevent vision-threatening complications. During comprehensive physical examination of a child with Apert syndrome, you perform careful spine assessment. Radiographic evaluation of the spine is being considered. What spine finding can occur in patients with Apert syndrome? Option A, spinal fusion never occurs. Option B, cervical spine fusion possible. Option C, only sacral abnormalities present. Option D, spine always completely normal. The correct answer is B, cervical spine fusion is possible. Some patients with Apert syndrome have vertebral fusion, particularly in the cervical spine region. While usually asymptomatic, these anomalies are important for anesthesia planning. Spine imaging should be obtained before surgical procedures. Knowledge of vertebral fusion prevents complications during intubation and positioning. Regular neurological assessment monitors for any spinal cord issues. An infant with Apert syndrome presents with increasing irritability and head circumference crossing percentiles upward. Neurological examination is performed urgently. What finding suggests increased intracranial pressure requiring immediate intervention? Option A, normal fontanelle. Option B, sunset eye sign and bulging fontanelle. Option C, hypotonia only. Option D, normal developmental milestones. The correct answer is B, sunset eye sign and bulging fontanelle. The fused skull sutures prevent normal brain growth, causing increased intracranial pressure. Warning signs include bulging fontanelle, downward eye deviation called sunset sign, irritability, and vomiting. This represents a neurosurgical emergency requiring immediate imaging and intervention. Early cranial vault expansion surgery prevents permanent neurological damage and developmental impairment. Parents of a child with Apert syndrome request genetic counseling for future pregnancy planning. They ask about the genetic cause. Molecular testing is being discussed. What gene mutation causes Apert syndrome? Option A, TWIST1 gene. Option B, FGFR2 gene. Option C, MSX2 gene. Option D, FGFR3 gene. The correct answer is B, FGFR2 gene, which stands for fibroblast growth factor receptor 2. Two specific mutations account for nearly all cases, S252W and P253R. These mutations cause premature fusion of bones in the skull, hands, and feet. Inheritance is autosomal dominant, but most cases occur as new mutations without family history. Genetic testing confirms diagnosis. A couple has one child with Apert syndrome. Neither parent carries the FGFR2 mutation on genetic testing. They are planning another pregnancy and ask about recurrence risk. What is the recurrence risk for future children if no parental mutation is found? Option A, 50% risk. Option B, 25% risk. Option C, very low, approximately 1%. Option D, 100% certainty. The correct answer is C, very low, approximately 1%. When neither parent carries the mutation, the case represents a new spontaneous mutation. Recurrence risk is very low, though germline mosaicism creates small residual risk. Advanced paternal age slightly increases new mutation risk. However, an affected individual has 50% chance of transmitting the condition to offspring. Genetic counseling provides personalized risk assessment. A newborn presents with physical findings suggestive of Apert syndrome, including abnormal head shape and hand syndactyly. Imaging is needed to confirm craniosynostosis. What imaging study is most appropriate as the initial diagnostic test? Option A, MRI brain with contrast. Option B, skull X-rays or CT scan. Option C, PET scan. Option D, ultrasound only. The correct answer is B, skull X-rays or CT scan. Computed tomography provides excellent bone detail, clearly showing fused sutures. Three-dimensional reconstructions help neurosurgeons plan operative approach. CT identifies the specific pattern of craniosynostosis. While radiation exposure is a consideration, the diagnostic information is essential. Low-dose protocols minimize radiation. MRI better evaluates brain tissue but poorly shows bone detail. A child has clinical features consistent with Apert syndrome. The family requests definitive diagnostic confirmation. Molecular genetic testing is being ordered. What test confirms the diagnosis of Apert syndrome? Option A, chromosomal microarray. Option B, FGFR2 gene sequencing. Option C, karyotype analysis. Option D, biochemical testing. The correct answer is B, FGFR2 gene sequencing. Direct sequencing of the FGFR2 gene identifies the specific mutation causing Apert syndrome. This targeted approach is efficient since two mutations account for most cases. Positive results confirm diagnosis and enable accurate genetic counseling. Testing allows prenatal diagnosis in future pregnancies if desired. Negative results don't exclude diagnosis if clinical features are typical. A child with Apert syndrome presents with developmental delays and new onset seizures. Brain MRI is ordered to evaluate for structural abnormalities. What brain finding may be present in patients with Apert syndrome? Option A, brain structure always normal. Option B, corpus callosum abnormalities possible. Option C, cerebellar agenesis typical. Option D, hydranencephaly common. The correct answer is B, corpus callosum abnormalities are possible. Some patients have partial or complete absence of the corpus callosum, the structure connecting brain hemispheres. Ventricular enlargement may also occur. These structural brain differences contribute to developmental and cognitive challenges. MRI imaging helps explain neurological findings and guides therapeutic interventions. Early identification allows appropriate educational planning and support services. Parents report their child with Apert syndrome snores loudly every night and appears tired during daytime. The child occasionally stops breathing during sleep. Polysomnography sleep study is recommended. What condition is being evaluated with this test? Option A, narcolepsy. Option B, obstructive sleep apnea. Option C, restless leg syndrome. Option D, insomnia disorder. The correct answer is B, obstructive sleep apnea. The midface hypoplasia and upper airway narrowing cause frequent breathing pauses during sleep. Polysomnography measures oxygen levels, breathing patterns, and sleep quality. Results guide treatment decisions. Mild cases may improve with positioning, while severe cases require continuous positive airway pressure or surgical intervention. Treating sleep apnea improves daytime function, growth, and cardiovascular health. A 6-month-old infant with Apert syndrome is being evaluated by Craniofacial surgery team. Parents ask about timing for cranial vault remodeling. The child shows normal development currently. What is the optimal age for first cranial vault surgery? Option A, immediately at birth. Option B, 6 to 12 months. Option C, after 5 years old. Option D, adolescence only. The correct answer is B, 6 to 12 months of age. Early cranial vault expansion allows the brain to grow normally during critical developmental period. Infant skull bones are more malleable, facilitating surgical remodeling. Surgery performed during this window reduces risk of increased intracranial pressure and associated complications. Delaying surgery may compromise brain development. However, timing is individualized based on clinical findings. An 8-year-old child with Apert syndrome has severe midface protrusion causing breathing problems, dental issues, and appearance concerns. Craniofacial team discusses mid-face advancement surgery. When is mid-face surgery typically performed in Apert syndrome? Option A, infancy only. Option B, school age to adolescence. Option C, never indicated. Option D, after age 30. The correct answer is B, school age to adolescence. Mid-face advancement surgery is typically delayed until approximately 7 to 12 years of age. This timing allows for sufficient dental development while addressing functional problems like airway obstruction and malocclusion. Lefort 3 osteotomy with gradual distraction advances the mid-face forward. Surgery significantly improves breathing, bite alignment, and facial appearance. Multiple procedures may be needed. A 1-year-old child with Apert syndrome type 2 hand classification is ready for surgical release of syndactyly. Multiple stage procedures will be needed. What is the first surgical priority for hand reconstruction? Option A, release all digits simultaneously. Option B, release thumb and radial digits first. Option C, release fifth finger only. Option D, no surgery until adolescence. The correct answer is B, release thumb and radial digits first. Initial surgery focuses on creating functional thumb opposition, essential for grasp and manipulation. This is performed around 6 to 18 months of age. Subsequent procedures separate remaining digits in stages. Releasing all digits simultaneously risks vascular compromise. Multiple operations over several years achieve maximum hand function. Physical therapy optimizes outcomes between surgeries. A family with a child with Apert syndrome attends numerous medical appointments. They ask which specialists are essential for comprehensive care. The team is explaining the multidisciplinary approach. What specialist is not typically needed on the core craniofacial team? Option A, neurosurgeon. Option B, geneticist. Option C, dermatologist. Option D, ophthalmologist. The correct answer is C, dermatologist is usually not on the core team. Essential specialists include neurosurgeons for skull surgery, plastic surgeons for craniofacial reconstruction, geneticists for counseling, ENT for airway management, ophthalmologists for eye problems, and dental specialists. Speech therapy, audiology, and psychology provide developmental support. Coordinated multidisciplinary care delivered by experienced craniofacial teams produces the best outcomes. A child with Apert syndrome reports worsening vision that doesn't improve with glasses. Parents notice the child squints and sits closer to screens. Ophthalmology consultation is urgent. What complication threatens vision in Apert syndrome? Option A, simple myopia. Option B, optic nerve compression. Option C, conjunctivitis. Option D, presbyopia.